Hey, good morning, everyone. I'm Dr. Steve Stites, Chief Medical Officer here at the University of Kansas Health System and Executive Vice Chancellor at the University of Kansas Medical Center. Today, on a special Friday edition of Open Mics with Dr. Stites. Yes, it's not Wednesday, it's Friday, but we get to have one of my very favorite shows. We've gathered 6 chief medical officers and infectious disease specialists from across the metro and throughout Kansas, including myself and Dr. Dana Hawkinson. It's been 7 months since we've had a status report on COVID. So we'll take a look at that, plus see what you can expect from influenza, RSV, and other things as we head into the fall. And after we hear from our docs, we will open this up to reporters in the community for questions. Members of the community should put their questions into the chat feeds in Facebook, YouTube, or email us at medicalnewsnetwork@kumc.edu. Jessica Lovell will monitor those feeds for questions. Let's get started. All right, across the country, according to this COVID data tracker from the CDC, you can see test positivity is up. Emergency department visits are up. Hospitalizations are up. And you can also see in this graph from the CDC, nationally, the wastewater viral activity level is currently very high. Wastewater monitoring may provide an early warning that levels of infections are increasing even when people don't have symptoms. We've been following wastewater testing for years. And when we isolate the Midwest trend, we can see that that level in the Midwest is rising just like the rest of the country. Now here's a look at the COVID picture nationally. To achieve that, we're going to talk a little with each one of our experts. And I said nationally, I mean locally. Let's bring in Dr. Dana Hawkinson, Medical Director of Infection Prevention Control at the University of Kansas Health System. What have our numbers been looking like, Doc Hawk?
Yeah.
Man, I can't say the whole Dana Hawkinson thing. That's just not going to work.
That's all right.
Doc Hawk.
That's all right. You know, unfortunately, Steve, we talked about this before. We had higher numbers, I think 21, 24. Our numbers of inpatients went down to 17 a couple weeks ago. We were hoping that would be a trend. Unfortunately, our latest numbers taken last evening show that we have inpatients for 21. So our numbers have gone up slightly. You know, we were hoping, again, overall a decrease in the trend and the numbers, but right now we have 21 inpatients.
So I should note that according to the Center for Medicare and Medicaid Services, hospitals are going to be required, starting in November, to report COVID numbers once again. It's something we have not had to do since May 1st of this year. They will also have to report influenza and RSV cases. Talk to me about that. I think it's great.
I think that's very good. You know, we are going into respiratory viral season, so that obviously includes COVID-19, but remember there are other respiratory viruses, influenza and RSV, and I think it is the best thing so that we can collect that data to understand what are trends around the nation, what are trends in the regions, and what are trends locally. Just as you said, there was a mandate that we did not there was a mandate to stop. We didn't have to report, and a lot of hospitals stopped reporting, but now the mandate will be back in starting November 1st, where hospitals, especially in acute care hospitals and emergency access hospitals, are all going to have to report those numbers to NHSN. I think it's just more data to use to support and provide the best care and understand the trends going around in our communities.
So for those who think COVID is in the rearview mirror, unfortunately, we have to rethink that one again. It's time to hear how COVID cases are looking across our metro and the region. We're thrilled to have with us today Dr. Mark Steele, Executive Chief Clinical Officer, University Health, Dr. Chakshu Gupta, CMO at Liberty Hospital, Dr. Bill Gilbert, CMO at St. Luke's, and Dr. Sri Dhanapudi, CMO at the University of Kansas Health System in St. Francis. Thank you all for joining me and Dr. Hawkinson, Hawkeye, this morning. You saw what the COVID number has been like at our health system. Let's see what numbers are like across hospitals in the rest of our metropolitan area and in our region. Let's start. Let me start, first of all, with Bill. Bill Gilbert, how are things going on up in St. Luke's?
St. Luke's, we have 4 metro hospitals and 4 critical access hospitals. Currently, across those 8 hospitals, we have 21 inpatients that tested positive for COVID. Of those, 4 in the ICU and 1 is on a vent. Interestingly, none are at the critical access hospitals. There's 7 at St. Luke's Hospital, 8 at St. Luke's East, and 5 at St. Luke's South. none at St. Luke's North. We also still monitor flu and RSV. We have no flu or RSV cases that are hospitalized currently across the system.
That's great, but 21, don't like that number. I mean, I liked it better when we were in single digits. How about you?
I agree.
Yeah, that was a lot better. Okay, Dr. Mark Steele, Executive Chief Clinical Officer, University Health. How are things going, sir?
Yeah, good morning, Steve. Going pretty well. This morning, we have a total of 7 patients that are in isolation due to COVID. This is actually a little down from last week when we were up to as high as 14. The other thing, we have none in the ICU, so that's a good thing. One thing I would mention is that our test positivity for COVID last week peaked out at about 25%, and this week now we're down to 12%. So I'm hoping that that may be a good sign that we're seeing a little bit less COVID circulating. And the other thing I would note is that we certainly have seen an uptick in cases of COVID within our employee workforce for about the last 6 weeks or so. I mean, not as high as a couple years ago, but we've had more people out than we did prior to that 6-week period.
I want to come back to that test positivity rate of 25%. Dude, that's high.
Mm-hmm.
Yeah, no, it's absolutely. I mean, that's higher than it was last summer as I look back, and so yeah, clearly there was. And I think we all know people that are getting COVID, and as well as people we work with.
Yeah, and that's been my experience in my outpatient clinic. I've had a lot more people getting positive. Mm-hmm. Dr. Chakshu Gupta, CMO Open Liberty, talk to us a little bit what things like up in the Northland for you.
Yes, good morning. Hello from the Northland. So just like in the country and in the region, our test positivity rates have kind of been going up since the mid to end of July. We were about 5 to 6% up until late July, and now our current positivity this week is 17%. In addition, our inpatient numbers that are sick with COVID have also gone up. For the past several months, we had 1 to 2 patients in the hospital at any time with COVID. We now average between 6 to 8 patients. That's about 4% of our inpatient census, so that certainly has gone up as well. And since the rates are going up in the community, we also see some of our employees that are getting sick with COVID and having to excuse themselves from work. Yesterday's number was about 5 employees. And given our very tight labor force, that does impact our hospital operations, but we are doing everything we can to mitigate that risk. The one thing that I show all the folks that I speak with in the hospital and in my communities is this is a positivity rate at Liberty Hospital. The black lines is 2024 and the gray line is 2023. And you can see we had a similar bump just a few weeks apart last summer. As you can imagine, this is people just before their vacations are done trying to congregate, go enjoy their vacation before school starts. Certainly when school starts, a lot of kids getting together, families getting together, and waning immunity from previous year's vaccination. So all of these things, I think, are causing the bump in the positivity rates.
Yeah, I think that's a great analysis. Let me turn now to Dr. Try that again. Turn to Dr. Sri Dhanapudi, the CMO at the University of Kansas Health System at St. Francis, and speak up.
Good morning. So our positivity rate's been running quite a bit higher. We need to be being even more aggressive with our testing, but about 50% is what we saw in the month of August. We did have a pretty quick uptick in our number of inpatients. Certainly don't have the overall census that some of your facilities have. The highest we got at one point, I think, was 8, but not a lot of ICU or high ICU needs, and we were down to 1 currently. So kind of a quick spike and a quick drop back down. But the current rates and the number of admissions that we're seeing related to COVID are on par with what we had back in January of 2024. So, relative to that winter spike that is more commonly seen and expected. So we're also not seeing any flu or RSV in our either much in our testing or in the hospital, and had initially seen more flu A. And are now starting to see more flu B, but no hospitalization. So for those that have been getting admitted with respect to COVID, have typically not been a lot of high acuity, high ICU level type of care needs.
Yeah, it's, you know, the test positivity thing is a spooky thing, Hawkeye, because it shows that people are getting tested, and we know there are a lot more positive tests going on at home.
Yeah, I think there's a lot more illness at home. There's a lot more tests at home. There's a lot of people who aren't testing. I think that is just more indicative of the amount of circulation of the virus in the community. I think that's actually right. You know, a lot of people that we are talking about in the health systems are not getting tested unless they have a symptom. And so just as you said, Steve, and we've heard from our guests, when you have a test positivity rate of 25%, that is an extremely high. And you have to imagine that out in the community, there's even more people who are testing at home, but also maybe people who aren't testing at home. So it just, I think, is indicative of a high level of circulation of the virus in the community.
Yeah, and we heard as high as 50%, which is, oh, that hurt my heart a little bit right there. So, Bill, you know, you and I have been through this, and Mark, we've been through this a couple of times, right? We've been through these cycles now. We've been in these roles long enough that we're not surprised by anything. But are you surprised by this sort of this mini comeback that COVID made this summer of all times when people are outdoors?
I really am not. You know, this is a very tricky virus, as I'm sure some of our experts can explain a bit more, but it mutates a lot, changes a lot, and when we think we've got it beat, we don't. And that's just the way it is. Hopefully the new vaccine will help us a little bit.
Mark, still using Paxlovid with your team, still seeing pretty good results from that?
Yeah, we're getting a lot of requests for it, and we get a request, we'll prescribe it. I won't go over the studies. I think it's probably more appropriate for people with multiple comorbidities that are at risk of hospitalization. But we get a lot of people that, if they test positive at home, they send us a patient portal message and they want Paxlovid.
Mark, your population is a little different. You represent a different segment or group of folks for us here in our society. Tell us how it's impacted things at Truman.
Yeah, well, I don't think it's impacted us terribly. I mean, so far, and I would agree with Bill that I'm not totally surprised. I mean, and I think what we're seeing with this summer surge is not dramatically different than last year, although maybe a little bit. It's lasted a little bit longer. But obviously that part of that's probably related to the changing subvariants, the fact that we've not had as many people updated on their vaccines as we would particularly like. And then, of course, when it got hot, people sort of tend to go inside and gather and travel and all that stuff. And so I think some of that seems to be the new norm in terms of what we've seen with COVID so far.
Yeah, I would agree. And I'm sorry I said Truman. I meant University of Health. My apologies. I'm just old, man. I've been here for too long. Chuck Hsu, as you look at this story out there, it feels like influenza didn't go away this year. I mean, I'm still seeing positive results in my clinic. Are you seeing that up in Liberty?
Yes, that's a wonderful point. We actually have 3 cases just this week that were positive for influenza A, and we had 1 case positive about 2 weeks prior as well. And one of them, or maybe 2 of them, are co-infections with COVID positive patients.
So lots of it still out there. Sri, are you seeing the same thing out in Topeka, kind of this whole milieu out there of influenza, RSV, and COVID, all kind of intermixed?
So far, we're really not seeing a lot of, certainly not any RSV
Good.
So far. And we had a little bit of flu, but nobody that's needed to be hospitalized for it. So not going to look.
All right. So, okay. I'm surprised. I saw a lot of influenza continued throughout the summer. That's not our normal trend. It should have been gone.
Yeah, I mean, we would expect lower levels, and we certainly have seen lower levels from what they were last winter, but I think just as you're talking about, still that low level of activity is concerning. It was co-circulation, or is co-circulation of A and B, but thankfully it is lower, but not so thankfully. the Southern Hemisphere is now getting out of their influenza season, and now we are getting into our influenza season. I think really what we need to see is, will we have an early peak, say in November, December, as we had a couple years ago, or will it be a later peak like we normally see? I think that remains to be seen at this point. But what we do know in the Southern Hemisphere, now that's not fully indicative of what will happen here in the Northern Hemisphere, is that overall they are back to pre-pandemic levels of viral circulation. So when they compared 2017 to 2019, and again 2022 to 2023, it tends to be more of the influenza seasons like before the pandemic. Also, we can say that in the Southern Hemisphere, they had, in South America, they had more H3N2 disease, whereas in Oceania and places like Australia, they had more H1N1 type disease. Now, luckily, our influenza vaccines will contain both of those, as well as a B viral strain as well.
So, team, the FDA just approved 2 new COVID vaccines. They are vaccines, not just boosters. Now, tell us why that's significant. Hawkeye, help us out here.
Yeah, I think we have to understand they're not called boosters because they are just like influenza vaccine, really going to be recommended yearly from this point on, as far as we know. They're not a booster because we don't call get your influenza booster. We say get your influenza vaccine for the season. That is going to be the same here. And we should say that the newest COVID vaccines should be out of the warehouses and making their ways to the health systems and clinical pharmacies as well, or commercial pharmacies. It will be the KP.2 variant, which is a closer variant to what is circulating and dominating right now as compared to earlier in the spring as well, but it will still provide good protection against severe disease and hospitalization. That is the anticipation. We will ultimately have to see, but remember, just as we heard our guest talk about how it mutates the virus itself, remember a lot of that mutation is due to the spike protein, so we do lose our antibody immunity, and that's why these vaccines are going to help to give a boost to that antibody immunity. But we still have that very good T-cell immunity, which has really been conserved throughout all the variants by 80% or more, and so that is what really protects us from severe disease and hospitalization, and we will get our boost of our T-cell immunity from the vaccine as well.
So just to say out loud, this is still Pfizer and Moderna's vaccination and messenger RNA base, clearly safe, billions of times been given all around the world. Still a lot of innuendo, a lot of stuff out there, but these are very safe vaccines. And Novavax is supposed to, if you don't want to do mRNA, I think the Novavax is just a few weeks behind, hopefully. Yeah,
and I would say as far as safety, we have always promoted that and endorsed that and reported on that. There was a recent article, I think it was in the JAMA Network, that recently came out that looked at people who got vaccination or infection or other infections with viral diseases and looking at myocarditis. And we know that the vaccine can cause myocarditis, but what they found in this study was that actually myocarditis happened more often with the actual viral infections, and it was worse than compared to those people that got it from vaccination.
Yeah, so clearly a better choice overall.
Yeah.
Mark, what do you think the uptake of our vaccines will be this year? I mean, it wasn't great last year. You think that's changed this year? Any more truth out there?
I would like to say yes, but I don't think that's the case. I'm afraid that it may be very similar to what we saw the last go around. But obviously remain hopeful, and certainly we all will be encouraging our patients and others to get updated.
Our experience has been very safe vaccine. Your thoughts?
Yeah, no, absolutely. Yeah, very safe, as was alluded to, and for the most part, little sore arm, and that's about it for most people who get the vaccine.
Yeah, it makes sense. So, Chuck Hsu, I know you study these things pretty religiously. Tell me a little bit about your thoughts. What's the uptake going to be like up in northern Missouri?
That's a great question. We very strongly encourage vaccination, both in our communities and, of course, for our healthcare staff. Vaccination is a wonderful way to prevent severe COVID. One of the misunderstandings out there is that, hey, I know someone who got the vaccine, they still got COVID. And we need to message this properly. The idea of getting vaccinated is not to quote unquote prevent COVID is to prevent severe infection with COVID. Of course, the more people that get vaccinated, the more protected you are. So there's a sense of community protection as well. It is very disappointing to be in such a great nation with such educated, informed population, and our vaccination rates against such a severe illness is in the low, I think the 15 or 20%. It's very, very low. I would hope that we do our job as healthcare educators to promote vaccination and bring the vaccination rates to as high a level as possible.
Yeah, I totally agree. So now let's talk for a moment. I'm going to shift gears to RSV. The CDC recently updated its recommendation of the use of respiratory syncytial virus for vaccines in people ages 60 and older. I'm going to come to that number 60 back here in just a moment. And yes, Bill Gilberts, that's going to be about you and I. For this upcoming respiratory viral season, the CDC recommends everyone ages 75 and older receive the RSV vaccine, and people ages 60 to 74 who had increased risk of severe RSV, meaning they have certain chronic medical conditions like a heart or lung disease, or live in nursing homes should also receive the RSV vaccine. Let's find out what we're seeing so far this year and what we expect in RSV cases. Sri, I'm going to start with you. You mentioned not a lot of RSV up in Topeka anymore, but recommendations. What do you think about these new recommendations coming out of the CDC?
Absolutely. I mean, for us, for our community in particular, we have an older community overall, and certainly aging. We're going to be at higher risk. So certainly every intervention that can help protect them and keep them well and living their lives in the best manner that they would like to and we'd like to see, and keeping them out of the hospital would be optimal. And so anything that we can prevent, I think sometimes it's that misnomer of, oh, well, it's just going to be a cold and I'll get over it and, not have to take those maybe preventative measures, but we don't know that. And it can wind up being quite severe when you have these other risk factors for winding up in the hospital and then wind up with other complicating infections and conditions.
Yeah, indeed. So Bill, now I'm maybe you're under 60. I don't know. I know I'm over 60 and have enough conditions. Should I go get the RSV vaccine? What do you think about these new recommendations? Should people, maybe like you and I, be getting the RSV vaccination?
Well, Steve, I'm a vaccine advocate and always have been. So as soon as it came out, I was 65. I went and I got it. My wife got it. And now I'm getting a recommendation that says, well, you don't really have any underlying diseases. You could have waited until you were 75. Why? If you can wear a seatbelt and it's going to protect you, your vaccine is going to protect you somewhat, even if you don't have immunosuppression for whatever reason. And that's kind of the way my informed patients looked at it when it came out. They all went out and got it. In Missouri, we had to write a prescription that went to the pharmacy to get the vaccine. But now, for people over 75, I have a little more leverage, and I can basically tell them, now it's indicated particularly for you, and I think you ought to get it.
Yeah, that makes sense. And Mark, I guess I left you out of the age equation. You look so darn young there, sir.
Yeah. Well, that's a good thing, but I am in that category of eligibility. So, I would just, talk about obviously all three of these viral illnesses, flu, COVID, RSV, have a greater impact on people who are 65 and older and all the other high-risk folks, those who have underlying medical conditions and immunocompromised. And so, it's particularly important that we get that cohort of patients immunized and updated. Obviously, we do a little bit better in that age category, but still not anywhere as high as we would like it to be. And the other thing I would just highlight is it's easy to sort of forget about long COVID and some of these pretty devastating symptoms that people can have last with them for quite a long period of time. And the only thing that's really been shown are there, if those who are vaccinated are less prone to getting long COVID than those who are not. So, and especially the long COVID seems to impact a little bit younger population.
Yeah, I totally Totally makes sense to me about that. Hawkeye, Bill's raised a good point about the RSV vaccine. When is the right time to get it, and how much disease you need to have? Because you can say, well, if you have any heart or lung disease, well, that's almost everybody at the age of 65. So how do you?
I think that's right. It probably just hasn't been diagnosed, maybe because they don't go to the hospital or they don't go to their doctor. So I think that's a very good point to start with. But I fall, under his opinion as well. I certainly support that. Obviously, it's perspective bias, but I support science. I understand the benefits that science has given us. I trust in it. It is right. It's recommended for everybody 75 and above, and then possibly with a talk with your provider, if you're 60 to 74, I would say just get it. We know that the risks of getting it are extremely minimal, but the benefits could be very, very great. So I would certainly recommend getting it. To any one of my family members or loved ones, if they were 60, I would say go get it.
So let's touch briefly on influenza. We know that influenza is usually the vaccines are based on what's going on in the southern hemisphere. There have been pretty consistent levels this year compared to last year, though a couple of countries popped up a little bit. Hawk, what are your thoughts about what influenza is going to be like this year?
Yeah, I think it'll be similar to what the Southern Hemisphere has shown. And again, I think we will have high rates like we have the last couple years and prior to the pandemic as well. What will that level be? It's hard to say. And again, what is the timing of that as well? When will we see a peak? Will it be in late November or December like we have seen a couple times in the past, or it'll be later, January, February? It's really hard to tell. But we know that the vaccines will help. Even when they're not matched perfectly, they will continue to provide protection against severe disease and hospitalization, even for those at risk.
So you can get all the vaccines at once this year?
Absolutely. You are able to get those vaccines co-administered at the same visit.
Awesome. All right, let's turn to Jessica Lovell, our excellent reporter in the studio, and see if we have questions on the line.
Hey, Dr. Stites, good morning.
Good morning.
Question from Jeremy.
It's kind of fun for you and I to be like this again, you know what I'm saying?
I know.
Usually you're here and I'm not, and now I get to be here and you're there. This is part. This is
I
like
know. I have no idea what's happening.
Yeah.
But I like it. So, okay, so first of all, Georgianne, who's been with this program since the beginning of COVID, said, yay. I don't think yay because we're talking about COVID, but she said yay because Hawk and Stites are back kind of together again. Talking about this.
It's like the odd couple. I'm the honest.
Very much so. So Jeremy wants to know, now that we've got some time behind us, since the pandemic began and so much research has been done since that time, has there been any notable strides in understanding and treating long COVID?
Unfortunately, no. It still remains treatment for the symptoms. Again, whether that is cough and shortness of breath, whether that's fatigue, muscle ache, brain fog. The symptoms the treatments are related to the symptoms. There is no one treatment for everything, but as one of our guests alluded to as well, the vaccines can help reduce long COVID, so that is one other reason to recommend and to get your loved ones to get the vaccine, the new 24-25 updated vaccine for COVID as well. But also what we have seen is that over time, many of the people will start to have resolution of their long COVID symptoms. But obviously we know that there still are millions of people every day who are dealing with long COVID symptoms. But to answer the question, there's been no specific treatment and not one treatment as well for any of those symptoms.
Dr. Donaphy, in Topeka, within your practice, are you seeing still a fair amount of long COVID coming about as a result of COVID?
I mean, I think it's certainly present. It's hard to really statistically know in terms of the overall prevalence of it that we're seeing. And there's so many other factors and so many other conditions which it can mimic. I mean, the symptoms can be very nonspecific in terms of fatigue and just general malaise, and there's some data regarding depression and anxiety that can be long-term sequelae as well. So those are things that people may not necessarily track back or connect back to the fact that they had COVID, and may just be, something they may attribute to even seasonal change or other factors that are going on in this life. So I think it's hard to necessarily definitively relate it back to that COVID history from a just anecdotal interactions and patient report perspective, but certainly out there.
Jess, back to you.
So a couple of back to basic questions from Pat and Jean. First, when is the best time to get a COVID test? And then if you get the test and it comes back positive, what are some of those protocols that we should be following?
I would say have a plan, and we've talked about having a plan. So yes, obviously, if you have symptoms, test. You may have to test a couple days if you're doing the at-home test, a couple days in a row, 24 hours apart, because we know the sensitivity isn't the best, but you should test. If you are positive, make sure you already have a plan in place. If you are at high risk of severe disease and hospitalization, it's vitally important to call up your physician or your medical teams to get placed on those antivirals. The most common, obviously, is Paxlovid. Paxlovid still works, is very effective in reducing your chances of going to the hospital. Also, the other one is molnupiravir if you can't get Paxlovid because of drug-drug interactions with some of the other medicines you're taking. But it's best to have that plan and call your physician or your medical teams once you know you are positive.
Pat also wants to know, do we know if the government is going to be offering free testing this year?
I've not heard of that yet. Mark, have you heard about this question?
Yeah, well, there's a report that they're going to give families 4 free COVID tests, and apparently you can get online and order these toward the end of September. And so, yeah, there is going to be some free testing.
All right. Hawkeyes are here giving us the thumbs up, so I guess that must be the story.
I think it's COVIDtest.gov, I believe, is where you go to order those.
Joellen wants to know, she says she's over 70. It's been 9 months since her last COVID vaccination. Should I wait until the new one arrives in 4 weeks? She says she has heart issues and high blood pressure that she's being treated for.
Bill, what do you think?
I think she better call CVS and Walgreens. Some of my patients have already gotten the new vaccine, so it's out there in the major pharmacy chains. And so I'd say get it.
Yep, and make sure she's up to date on her RSV vaccine if she hasn't had that as well, and then get influenza when it's out there.
Exactly.
Yen Liang wants to know, he says the monkeypox virus seems to have mutated and its transmissibility appears to have become stronger. Could monkeypox become the next pandemic?
Oh, I don't think it's going to be the next pandemic. What do you think, Hawk?
Well, again, I would just correct, it hasn't necessarily mutated. This strain is a different strain than we saw in 2022 that was circulating the globe. Certainly it can be a significant problem. We know the World Health Organization has determined it as a public health emergency of consequence. So it is vitally important that we be able to control this, and we do have the vaccine to control this. And as far as I know, we are shipping vaccines over to, I think it's Democratic Republic of Congo right now to help reduce that outbreak that is going on there, which is so severe. But we know there have been a couple of cases outside of that country, outside of Africa in general, in other countries of this clade 1b, which is really tending to be more severe, and this is what we're dealing with now. We hope that it won't. I think it is much more difficult than coronavirus, just as you said, Steve, because it isn't spread airborne or respiratory droplet. It is more of that close contact. So we're hoping it doesn't, but we know we have the tools to help prevent that, and we just need to make that access to those tools, i.e. the vaccine, more readily available.
Deb wants to know, how often do you receive the RSV vaccine?
Yeah, good question.
That's a great question. Go
yeah,
ahead.
So I think the best data we have is when it was being studied. It showed that it had activity for at least 2 seasons of RSV season. Right now, the recommendation is just to receive 1 dose. Now, as we get further into this, because again, the RSV vaccines just came out last year, As we get more data, clinical data, there may be a recommendation to get an additional dose. But if you've already received your RSV vaccine, right now there is no other recommendation to receive an additional dose. And we would say that this year there are 3 available. There are 2 protein subunit vaccines which were available last year, but now there's also a 3rd vaccine which is an mRNA vaccine as well.
You have a preference of which one you think is going to be the best?
They are all have the same efficacy of helping protect against lower respiratory tract disease, that means disease in the lungs, as well as going to the hospital and severe disease. So either one is fine.
A last question, Jean wants to know, how long should I isolate if I test positive?
For COVID, I'm assuming. All right, Chakshu, what are your thoughts?
Yeah, I can answer in 2 different ways. One is if you work in a healthcare facility, you need to, Liberty Hospital requires 5-day after being testing positive or being symptomatic. And once you return to work, you have to wear a mask. You have to mask for at least additional 5 days. Now, the second part of the question is what do you do in the community to protect your family members and others in the community? And I think you should follow similar guidelines. You should try to stay away, especially from the people who are older, have medical conditions, and are higher risk for getting severe COVID, and also wear a mask when out in public. The third thing I would add to that is always follow the recommendation of your healthcare provider.
You know, Hawk, this warms my heart of what Dr. Gupta is saying, but it's what we have been preaching and preaching and preaching and preaching and preaching and preaching since the beginning of this pandemic.
Yeah.
The rules of infection control keep you safe up until this moment and every day going forward.
Yeah, absolutely. They go with you wherever you go.
They go with you wherever you go.
They help protect you and the community around you as well. So.
This has been a great program today. I want to say thank you to all of the physicians who have been here with us today. I want to go around the horn and just ask everybody for final thoughts. I'm going to start with Dr. Bill Gilbert up with St. Luke's.
My thoughts are get the vaccines if you're in the age group that's indicated to get them, and don't delay. I'm still getting a ton of pushback from patients on getting a COVID vaccine, and it's not based in science, and it seems like I can't convince them otherwise, and that's very frustrating. The other caveat I'll give you, which is just really probably doesn't apply to many people, but amazingly for pilots, the FAA says if you get the COVID vaccine, you're grounded for 48 hours. Unlike any other vaccine. So just give you that little
that makes
tidbit.
A lot of sense. Yeah. Dr. Sri Dadaputi, the Chief Medical Officer for University of Kansas Health System in Topeka.
100% agree with Gilbert there. Ounce prevention worth pound of cure. Primary care doc, it's still the case. Whatever you can do to prevent it, both in terms of getting those vaccinations as well as just being smart. If you're going out, and you're around people or you're going to be in real close quarters, consider masking as an extra layer of protection. Consider distancing from folks when the community rates are running higher like they have been more recently. And just taking those precautions, frequent hand washing.
Indeed. All right. Dr. Chakshu Gupta, Chief Medical Officer of the University of Kansas Health System, Liberty Campus. Talk to us. Final thought.
Yeah, I would just dovetail on everything else has been said by this esteemed group. There is a lot of misinformation out there. I would encourage you to get the information from reliable, reputable sources. Talk to your healthcare providers. They have experience and the right information. Please do not get swayed by all the misinformation and the stuff out there. Vaccinations save lives. If you care about yourself, your family, and your community, I think you should take these vaccines: the COVID vaccine, the flu vaccine, RSV if applicable, and just practice common sense protective measures to save yourself, your family, and your communities from these dreadful infections.
All right, thank you. And finally, but not last, or what am I trying to say? Last but not least, Dr. Mark Steele, our Executive Chief Clinical Officer at the University of Health.
Yeah, not a lot to add. Obviously, I would just say to people that, all of us on this call, if a vaccine is indicated and we're eligible for it, I mean, we're all going to be out getting it, right? And as Bill alluded to, it's already available. The COVID updated one is available at CVS. My wife got it the other day. Wednesday, I think, was the first day it was available. Evidently, Walgreens is making appointments starting September 6th, and before too long, it'll be at the health departments and the health centers will be able to get a hold of it. And so it's just, it just is it makes a world of sense for people to do this, because it's all along the way, all these updated vaccines have been shown to reduce serious illness, deaths, long COVID. And so the evidence is pretty overwhelming that this is the right thing to do. And as was mentioned before, you can get the flu and the COVID together. And then for those who get the RSV, the same thing. So
I want to say a big shout out to all the four of our excellent physician executives who are on this program today. I also want to point out that you guys all have the same color scheme behind you. I don't know if that's collusion. I don't know what happened with that, but somehow people think this is the color to be a chief physician executive on the walls. All right, Hawkeye, final thought.
I mean, I think it is to echo all of our guest thoughts. I totally
Actually,
agree.
wait a minute. Dr. Sridhar, did I turn to you? I don't think I did I?
Yeah.
Okay, good.
Yeah.
There you go. All right.
I would start with hers. Prevention. Prevention is
that's
the best
it.
thing.
Yeah.
And we have the means to help prevent severe illness and hospitalization. And we know also that there is misinformation. We heard that. We know that a lot of people are not believing in the vaccines. They believe the COVID vaccine caused a lot of deaths. They believe that the influenza vaccine is not efficacious. Those things are false. We know that the vaccines do help prevent severe disease and hospitalization. And if you don't believe that, then just think about you having to go to work. Earning money is very important for people. Being able to go to work, or having their children not have to stay home, so they need to get childcare. If you talk about the economics, these vaccines will help reduce that financial burden because people will be well. They won't have to stay home. They can still earn money. They won't have to go to the hospital and be intubated and have those long hospitalizations. So there are many, many reasons why these vaccines help people on an everyday basis. Most of all, they help prevent that severe disease and having to go to the hospital. So continue to get vaccinated, and that will help protect you and your loved ones.
Just remember that internet science is not really science. There are still people out there who think the Chiefs didn't win the Super Bowl last year. Wrong.
Wrong.
And you're also wrong if you don't think we're going to win it this year. At some level, we have to make a decision in our lives about what we're going to believe in. We've demonstrated over and over again our commitment to telling you the truth, and that the combination of faith, hope, and science is far stronger than what internet rumors can ever try to spin. We hope you'll take this program to heart, and most importantly, we hope you listen to those of us who keep advocating for the safety, the efficacy, and the importance of vaccination, especially if you're over the age of 65 and you have any underlying medical conditions. Remember, faith, hope, and science. Together, we can. Thanks again to all of our guests. Thanks to all of our folks who listen, to all of our audience, to all the folks who work so hard in our studio to help put this program together. We'll see you soon.
Coming up Tuesday on the Morning Medical Update. Prostate cancer starts out silent, which is why Anthony Barnes has been speaking up ever since his diagnosis. I'm Jessica Lovell on the next Morning Medical Update. We kick off Prostate Cancer Awareness Month with a story of survival, the options given to Anthony, and the treatment he chose. Plus, why Black men in particular need to show up for one another. Tuesday at 8.
Subscribe to our Morning Medical Update and Open Mics with Dr. Stites podcasts. Now, everywhere podcasts are available.